Hi, we are the Sycamore Group, Nina Booth, Ryan Gorman, Marissa Collender, and Summer Park. Our social justice analysis will focus on social disparities in rural communities in New Mexico concerning opioid addiction. As we examine the opioid addiction within the state of New Mexico, a health disparity comes into focus. When looking at several different definitions of a social justice health concern, there is a disparity between rural and urban access to treatment within New Mexico, particularly naloxone utilization. Grayson Willis defines social justice as a fair distribution of both the benefits and burdens of societal living. According to statistics, rural communities in New Mexico have less access to opioid addiction programs. A day's model of vulnerability states that populations at risk include those with limited access to schools, jobs, and resources. Rural communities within New Mexico have been linked to all areas of a day's model of vulnerability, therefore making the clinical concern of opioid addiction and lack of access to naloxone a social disparity within New Mexico rural communities. Healthcare has lost its way in the shift from community and population-based primary care to a fascination with high technology and expensive pharmaceuticals. This has created an unstable health future with the focus shifting to hospital-based care. The socio-political knowing that the author theorizes reminds the informed nurse of the strengths of the profession and creates a change to become a proponent of policy change that will result in better patient outcomes. The author discusses 4 dimensions or arenas where this change in perspective can be further engaged and developed. The first dimension focuses on the practice of nursing, or more specifically, moving away from hospital-based nursing care into a more community-focused primary care nursing model. The second arena is within education. Here, the emphasis could be bridging the gap between the nursing model of care and the community's perception of what nursing expectations are to include. The last 2 arenas go hand in hand, improving the awareness and absolute need of evidence-based research in order to implement policy changes to benefit all populations, particularly those vulnerable to healthcare disparities. More than 42,000 people lost their lives in 2016 from overdose. New Mexico ranks as 8th in the nation for these deaths, with the vast majority coming from rural counties. Over 36% of counties in New Mexico are considered rural, and there are significantly higher rates of overdose in rural counties than metro areas. Rural New Mexico counties have significant disparities when it comes to overdose deaths. The drug overdose rate is greater than 30 per 100,000 compared to 26 in metro areas. The baseline morphine milligram equivalent is high in rural populations as well. Chronic opioid use is significantly higher in rural New Mexico. Despite the high levels of opioid use and overdose, rural New Mexico counties had the lowest rates of reimbursement for naloxone than any other area in the state. These graphs further emphasize health disparities in rural New Mexico. The utilization of naloxone has been shown to decrease community opioid overdose deaths. Naloxone is proven safe to treat life-threatening overdose. Increasing the access to naloxone in rural New Mexico communities would decrease the number of deaths associated with opioids. According to the socio-political theory, the community and primary care settings are proven to provide the best health outcomes for patients, particularly those in vulnerable populations. By allowing for community access to naloxone treatment, as well as changing policy to provide more access in rural communities, the health of those communities will only improve and ultimately thrive. Chronic opioid use rates are high in rural New Mexico, while access to naloxone is low. Educating providers to decrease opioid prescription is critical. Improved access to opioid treatment in New Mexico and compliance with the use of the prescription monitoring program are needed to decrease death rates. The second solution directly correlates with the socio-political theory. Emphasis is placed on education of prescribers towards a community-based healthcare, as well as knowing and understanding evidence-based research. Again, policy changes looking to mandate prescribers to utilize the prescription monitoring program in the state of New Mexico. The problem of rural New Mexico communities having less access to naloxone and opioid treatment centers might bring gains to hospitals, law enforcement or jails, and pharmaceutical companies. A solution to the opioid crisis in rural New Mexico would greatly benefit persons at risk for addiction and the communities affected. Persons with risk factors for opioid addiction include those with depression, anxiety, or other mental illnesses, those with a personal or family history of alcohol or substance abuse, those with a history of physical, mental, or sexual abuse, and those who have been on long-term use of opioid pain medications. The burden of cost associated with solutions to the opioid crisis is likely to fall on the government. Local providers may assume the cost of certification and training for opioid treatment, as well as the clinics or hospitals that employ them. The costs of treating patients for opioid addiction are likely to be covered by private or state insurances. There could possibly be financial responsibilities for patients and families as well. Using the Milstead process, agenda setting describes how issues gain attention from the government. In 2015, New Mexico had the 8th highest drug overdose death rate in the nation, and the consequences of drug use continue to burden New Mexico communities. Rural County of Rio Arriba had the highest drug overdose death rate in the state. Unintentional drug overdoses account for almost 85% of drug overdose deaths. The government's response was federal, and there has been a series of initiatives that have been created to combat the opioid crisis in New Mexico and improve access to care for rurally located residents. Some of these initiatives include the Opioid Antagonist Bill, which allows anyone to be in the possession of naloxone regardless if they have a prescription or not. Enforcement of the 911 Good Samaritan Law, which provides immunity from drug possession charges when a drug-related overdose victim or witness seeks medical assistance. Development and implementation of laws to decrease addiction and improve access to care in rural areas requires attention to social problems such as poverty, restricted access to adequate health care, and the unavailability of the opioid reversal drug naloxone. New Mexico is the first U.S. state to increase access to antidotes such as naloxone, and also to require local and state law enforcement agencies to provide officers with antidote kits. In 2016, a law was enacted to increase access to naloxone. This law allows non-clinicians to distribute the drug while operating under a standing order. The Hepatitis and Harm Reduction Program provides harm reduction prevention such as education, referrals, syringe services, and overdose prevention services. The Hepatitis and Harm Reduction Program trained over 2,000 people in 2016 in the use of naloxone. Over 800 people have reported successfully using naloxone to reverse an overdose. And in 2016, the New Mexico Department of Health distributed over 6,000 doses of naloxone. Pharmacists are now allowed to distribute naloxone. There were over 1,600 naloxone claims processed by Medicaid in 2016. The New Mexico Department of Health and Board of Pharmacy are increasing efforts to better monitor prescribing and educate providers to reduce opioid prescriptions.